Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to the Concussion Corner podcast. My name is Dr. Jessica Schwartz, and I'm thrilled to have Dr. Lenore Herget with us, joining us from Boston, Massachusetts today. Dr. Herget is a senior physical therapist, a board-certified sport clinical specialist, a certified strength and conditioning specialist, a certified clinical instructor, and a certified emergency medical responder at the MGH Sports Medicine Center. She is a member of the New England Patriots medical staff and serves as the concussion rehabilitation consultant for the Boston Bruins, Boston Red Sox, New England Revolution, Home Base Program, and MGH Sports Concussion Clinic. She received her Bachelor's of Arts degree in theater and psychology from Wheaton College, her Master's in education from SUNY in 2005, her post-baccalaureate pre-med certificate from Hunter College, and her doctorate of physical therapy from MGH Institute of Health Professions. Dr. Herget's practice includes rehabilitating athletes who have sustained a sport concussion, most specifically evaluating and treating high school through professional level athletes with concussions and assisting in their safe return to play. Her clinical expertise is in cervicogenic contributions and visual vestibular treatment of athletes and military personnel who sustain concussions, as well as the progression of exercise through exertional protocols. Her research has focused on management of athletes with post-concussive syndrome and the efficacy of pre-season and post-season visual vestibular testing to aid in return to play decision-making, alternative exercise testing protocols, atypical concussion presentations, and considerations in the military populations, as well as managing care for the female athlete triad diagnosis. She has lectured nationally on topics regarding concussion and other non-acute management of athletes with post-concussive syndrome. And additionally, she focuses her orthopedic practice on the biomechanical assessment and management of lower quarter injuries. Lenore, welcome to the Concussion Corner podcast.
Thank you. Great to be here. Thanks for having me.
Yeah, I say this, I've said this a few times, and, of course, I'm asking all of the close friends and colleagues to come on this podcast first. But just so our listeners know, Lenore, Dr. Herget is really one of my favorite physical therapists in this world who treats concussion. She is so in tune with her patients, with her treatments, with the lack of evidence and creating some new evidence out there at MGH. So really, again, I hope our listeners lean in for this episode and are ready to learn something.
No, thank you. I always learn everything from all of your podcasts and programs that you create. So it's an honor to be part of this. Thank you.
Yes. Yeah. I have to say, I started the world's first concussion education program for clinicians and physicians in 2000. Well, we started it in 2015 and it launched in 2016. It took over a year to build. And Lenore, Dr. Herget is in charge of our service member and visual vestibular section and specialty. So it really is an honor to have you on the podcast now as well.
Great. Thanks.
So, I have to say, you are a part of the medical staff of everything that I am the opposite of. I'm like a Yankees fan, I'm a Giants fan, all the things. So
I knew this was coming.
Yeah. So I'll let our listeners live on the edge a little bit there. But no, it's really good work that you're doing for our folks out there.
Thank you.
All right. So I kick off every podcast very Simon Sinek-esque, with starting with why. Kind of why you're doing this, why you got into concussion, how you arrived here, and then we'll kind of kick it off from there and let the listeners learn a little something.
Sure. So when I was finishing up my doctoral program in physical therapy and it was time to apply for my postgraduate year internship, I was really torn between sports medicine, which had been a part of my life as an athlete forever, and traumatic brain injury, which through rotations I had during school, I just really fell in love with that patient population and the creative and blending of art and science that went into managing those patients. So I applied to two very distinct programs, a traumatic brain injury rehab program and a sports medicine program. I ended up choosing the sports medicine or that's who I matched with. And it was great. But I always had that longing for, I really miss working with that TBI population. And then I went to a conference, a sports medicine conference, and heard Dr. Mickey Collins, neuropsychologist at University of Pittsburgh, talk about sport-related concussions. And this was about 10 years ago. And I said, that's it. This is it. This is how I can do both of the things I love. Sports medicine, TBI, mixed to one. Concussion, this is what I'm going to focus on. Of course, I was a new grad, so I had to still learn everything else. But I started attending every possible continuing education course that I could find, not just from a physical therapy realm, but I went to optometry conferences, neuropsych conferences, PM&R conferences. I just went to everything I could. I begged, borrowed, and pleaded to observe and shadow with some of the best minds out there. And after a couple years of this, I started to feel a little bit more confident about my knowledge base. And at the time, MGH was kind of desperate for somebody in the sports medicine, physical therapy department to start seeing these patients, because it was finally coming to light that, hey, we could do something from a rehabilitation standpoint, but we don't have anyone. Oh, Lenore, you seem interested. So it was kind of a hard work on my part, coupled with the right timing, coupled with a very supportive clinical director at my location who just allowed me to pursue everything I wanted and supported what I wanted to do. And so we started the MGH Youth Sports Concussion Clinic, which is now just a sport concussion clinic at MGH. And I became the rehabilitation consultant for them. And then that kind of snowballed into becoming the consultant for a lot of the different collegiate and professional teams around. And that's where I am today. And I love it.
Yeah, and I have to say, it's a common theme. I'm not trying to recreate the wheel here, because, so many folks like yourself, including Dr. Michael Furtado and Karen Scott that will be on, and, even Jeffrey Kutcher, physician. Essentially, most folks that are on this podcast, really, the timing is everything for us, right? So this last 5 to 10 years, it's just the data and the conversation around this has exponentially grown. And just timing is everything. And, a great quote from Michael, from Dr. Furtado that was on earlier, he said the biggest challenge in the last 5 or so years ago treating concussion patients were the gap in published literature and what we were seeing in clinical practice. I was wondering if you can comment on that and just kind of what have you seen in the last 5 to 10 years, versus what was published in a white paper?
Sure. So when I first started doing this, as you know, there was little to no evidence from vestibulopathy-related impairments after concussion. So we tried to pick and choose what we knew from vestibular literature in the geriatric population or other populations, fall prevention papers, and try to apply that to the concussed patient. But it's a very different can of worms, because we're dealing with an energy crisis. And so we can't keep, overstimulating to the point of desensitization or habituation for these patients. And so it was a lot of that trial and error in the beginning of how much to dose, which we still don't really know, but we're getting a little bit closer with dosing of exercises. And I think with the exercise intolerance piece, that was something else that, 8 or 9 years ago, when I first started doing this, a treadmill test didn't make sense to me, because if somebody had a lot of VOR issues, so gaze stability issues with an abnormal vestibular system, if they're bouncing up and down on a treadmill and they're getting symptomatic, how could we tell if that was true dysautonomia versus a gaze stabilization issue? So I just said, well, I'm going to put all my patients on a stationary bike. And then now literature is starting to come out supporting that. So it was a lot of kind of, let's try this because I don't think this quite works. We'll take what we know from the literature and add a little bit of our own trial and error and what we see anecdotally in the clinic. And it's amazing how month to month, I just feel like a better clinician. There's literature supporting part of what I do. I just feel more confident. My N has grown, so I anecdotally can put together better programs. And it's exciting because things are changing so fast, but that means we are changing as clinicians just as quickly and having to adapt. And I look back at patients from 2 years ago and I want to say, geez, I could have done such a better job with you. But I love that about this, is that we just keep getting better and better. And the literature is now either supporting it or it's being worked on to support what we're doing.
Indeed. And, I always say, like, I have no desire to sit behind a desk or collect data right now. I just want to promote what you guys are doing so well in the trenches, either producing literature and paperwork and white papers, and then also what you're seeing that anecdotally, that N of 1 turns into N of 100, turns into N of 1,000. And those are real numbers that we should really pay attention to and lean into with someone like yourself that's just doing this day in and day out.
Sure, absolutely.
Now, I know that you tend to specialize in the visual ocular motor side of this injury, the vestibular ocular motor side of this injury, and then the exercise dysautonomia part. You can join the club if you like. I just started it, I think, 2 days ago. I call it Team BDNF. So every time I don't want to go to the gym or work out, I just say,
you think of that BDNF. Yep, you need it.
It's like Miracle Grow for our hippocampus. And for the listeners that aren't in tune here, BDNF is brain derived neurotrophic factor, and it's essentially like Miracle Grow for your hippocampus region, which is basically so much of where our memories and everything is stored that make us human. So again, low load cardiovascular activity is so very important for this injury. And that's what we're kind of seeing now. And, for our listeners that feel stuck, and it's okay if you've given incorrect information. Now you're listening, you're leaning in, but we don't cocoon people anymore. And I'm sure Lenore, will nod her head, voraciously here. But we have to make sure that we are delineating between the difference between return to activity and return to play. And those two things are very, very important. So I was wondering if you could comment on what those differences are, Lenore, and then the importance of that low load cardiovascular activity. And then I'll lead in with a few more questions.
Sure. Yeah. And you make such a great point that it is a stark difference between returning to some form of cognitive or physical activity versus returning to full-fledged contact play. What we do know is after the first 2 to 3 days after sustaining a concussion, so that acute window, after that, there's no literature to support that there's any danger in a low-load, sub-symptomatic threshold exercise program for our patients. There is, in fact, literature to support that keeping them out of exercise can actually introduce other symptoms and other diagnoses along the psychosocial and emotional realm. So I'm either doing a formal exercise test with my patient initially, or just telling them, let's get on a stationary bike. Let's get your heart rate up a little bit. I don't want it to produce any symptoms. So if you start to feel a headache or any dizziness or nausea coming on, we're going to lower that intensity a little bit. But we want to get a little bit of exercise in daily, particularly for our athletes or our more active patients. This is who they are. This is whom they've always been. And so their body is going to thrive on that BDNF or those endorphins. And when we take them away, that's just one more thing that's being taken out of their life. I can't tell you how many patients I've had that have come to me after being managed elsewhere and being told to do nothing for 6 weeks, and they feel lousy, of course. And we're working on vision and vestibular and cervicogenic dysfunction. But as soon as I get them exercising, which is day one when I see them, if they are those people who are coming to me 6 weeks later, it's a world of difference. And, is it because they're perfusing their brain more? We're oxygenating the brain. Is it the BDNF? Is it the endorphins? Who knows? But I'd say D, all of the above. But it's very important that we do delineate between return to below symptomatic threshold activity very early on versus max exercising patients so they can get back to their prior level of activity.
Indeed, Lenore. And, it's so amazing because as a physical therapist, you can essentially treat and identify so many components of this injury, from the exercise autonomic dysfunction, cervical spine,
Mm-hmm.
Vestibular, ocular motor, post-traumatic headache, and migraine. I mean, if we're looking at 4 of the 6 trajectories just based off of UPMC trajectories and then add exercise as a 7th, essentially you can treat 5 of 7 of those, direct access as a physical therapist, in conjunction with an interdisciplinary team. And then the anxiety, mood, and cognitive components often settle down once vestibular, ocular motor, chronic pain, and post-traumatic headache and migraine settle down. Everything else just also settles down. So what are you experiencing there, with that statement of you just can't treat this one thing. You just can't treat the headache, or you just can't treat the cervical spine. What are you seeing in your practice?
So we are very fortunate as physical therapists that we are able to assess and manage 5+ of these trajectories. And the trajectories that UPMC have put forth have been very helpful, particularly when we think of patients not following just one, but multiple. I don't think I've ever had one patient who has fallen under just one trajectory pathway. So being able to assess all of these and develop treatment plans that take bits and pieces of each clinical pathway is going to get our patients better more quickly. And as far as the anxiety, mood, emotional trajectory, I find that when patients start exercising, that takes care of a lot of that as well. So maybe we don't directly treat that, but certainly indirectly we can help.
Indeed. And I have to say to our neuropsychology and psychology brothers and sisters that are across the aisle from us, they're doing wonderful work because they've been publishing on this since 1989 when Jeffrey Barth commented on this with the SLAM concussion trajectory, talking about concussion in sport really for the first time. But the difference here is that today in 2018, when we don't know what to do with somebody in healthcare, we send them down 2 trajectories. We either allude that they're malingering or faking it because, hey, Dr. Schwartz, can't figure this out. There's a level 10 of sarcasm for folks that are listening. Don't take that as a direct quote. And so this must be, all in your head, literally and figuratively. Or B, we allude that they need to see psych and actually need to talk out their problems from a mental health standpoint. With concussion, 5 of those 7 trajectories all have a mood and behavioral and component. So we're seeing, anxiety overlays with vestibular symptoms. We're seeing anxiety overlays with ocular motor, cervical spine, post-traumatic headache, and dysautonomia. When somebody walks in the supermarket and says that they either have like an oscillopsia or visual motion sensitivity or spatial motion discomfort, folks don't know how to subjectively express what and how they're feeling. So they just feel like they're going crazy. So then they go report this potentially to an untrained provider, and then they're prescribed medication for anxiety or mood disorders. But really it's coming from somatic stem, literally our brain stem and everything around it. So what have you seen there, as you've come up and through?
Well, I think you kind of nailed it on the head that when they are reporting this to an untrained provider, it can be very frustrating and debilitating to them. And so I found that sometimes when I'm asking very pointed questions, when you are walking through the supermarket, does it look like things are moving on the shelves when you know they're not? And it really empowers them, like, hey, these symptoms are real. This person knows what I'm talking about. And I tell them, we can work on this. This, just like anything else, we need to desensitize the system and start to gradually expose it to more provocative stimuli so that you can tolerate all of this. And I feel like it's like a light goes off in their head that they don't think they're crazy, and this provider doesn't think I'm crazy, and I don't just need to take a pill, which wouldn't probably work anyway. So I think being able to identify the different somatic systems that this is a function or a dysfunction of is helpful for them to buy in to rehab, and then they can see that what we're doing is really beneficial to them.
Indeed. And that's so important for the listeners to kind of lean into and pay attention to Lenore, Dr. Herget here, because she essentially just said the word rehab. And 2017 was the first formal year internationally that we've agreed that this is a rehabilitative injury. Concussion is treatable. Now, those of us that have been doing this for a while and have been in the quote unquote know, especially as physios and in the rehab world, know this. We've been rehabbing moderate and severe TBI since like the get-go. For historical components for our listeners to kind of pay attention to, physical therapists were rehabilitation aides first. Our profession is a young profession, and we started at World War I as rehabilitation aides. But what was happening then? Those were head injuries. And we were rehabilitating the servicemen that were injured at war. So no different than our modern severe TBI patients, traumatic brain injury. We've been rehabbing those guys forever, right? I mean, I mean, Lenore is probably like, just nodding the head. I can feel her through the Skype call. But, why have we been telling folks for like a century now to essentially rest and cocoon themselves after a concussion? So we have to take this active approach and utilize folks like Dr. Herget in the rehab world to get folks back using a pace-graded exposure, mindset.
Absolutely. No, that's very well said. And I mean, you point out that for years people were cocooning folks with concussion. Can you imagine doing that with someone after total hip replacement or after a cardiac catheterization, telling them you're just going to sit and do nothing for a couple weeks till you feel completely fine? So why do we do that with this? But we're not anymore. And that's the beauty of your podcasts and your programs.
Yes, the goal is to reach as many out there. But really, think about it, right, Lenore? Like, we take an oath to do no harm. And what we do, we may not have realized, and we sure are trying to get this message out now, but you're actually doing a harm component if you're actually telling someone to cocoon themselves and, lock yourself up in a dark room from both a psychological and a physical component. Absolutely.
We've got literature to support that now. We assumed it before, but now we can actually say, yes, this is more harmful.
Yes, indeed, and so spot on. I was wondering, we have about 10 minutes left here. I was wondering if you can kind of give the listener like a lens into your day and maybe let them know, like, hey, what does your initial evaluation process look like? And then also, who are some of your interdisciplinary team members that are either referring to you or you're referring to?
Sure. So an initial evaluation would consist of a very thorough subjective history, because this is really where I'm getting at the mechanism of injury, the care since the injury, and then I'm asking those really pointed questions that will help guide my exam down one or more likely multiple trajectories of oculomotor dysfunction, vestibular dysfunction, cervical spine, exercise intolerance. So it's a pretty lengthy subjective history. I take a little bit longer with these folks than my musculoskeletal patients. I usually, after that, I'll start with the oculomotor system and looking at, I'll do an adapted VOMS, the vestibular ocular motor screen from the UPMC folks. And so that includes smooth pursuits, a COD measures, near point of convergence, a VOR, vestibular ocular reflex gaze stabilization measure, and a visual motion sensitivity measure. And then I dig a little bit deeper if warranted, and we'll look at ocular alignment as well as some cross-cover tests if I'm suspecting there is a misalignment that may contribute to a more protracted recovery. I have a computerized eye tracking device by the company Think. It's called iThink, that has these real high-speed cameras and these goggles and hundreds of infrared sensors, and they just constantly are taking pictures of your eyes in time in relation to a moving target. And so it gives us some computerized objective data as far as how well our eyes are controlling our anticipatory saccadic movements, which is a dysfunction after concussion. And then I will move into a little bit more of my vestibular exam, so getting more in depth with my gaze stabilization with a dynamic visual acuity measure, head thrust tests, more visual motion sensitivity to identify exactly what sort of frequency and background exposure that they can tolerate. Then I look more at my static and dynamic measures of balance. So if it's more acute, I'll do a full BESS exam, which has the most sensitivity after, within the first 3 days after concussion. But I'll still use it kind of as a baseline measure because I like to add a cognitive dual task to my static exam. time tandem gait with a cognitive dual task, walking with head turns, so kind of measure some of the pieces of the DGI, and then a Fukuda step test. And then if you're getting bored, you can turn me down for a minute. Then I'll go into my cervical spine screen, looking at active range of motion, a quick palpation, look at deep cervical flexor and extensor strength and endurance, and then some proprioceptive measures with a swivel chair test, a smooth pursuit, neck torsion test, and a joint position error test. And then I'll go into the exercise screen, which I do a modified Buffalo protocol on a stationary bike.
Whew. Now, I'm exhausted. Goodbye.
Right.
I know that was great.
And obviously, I won't do that all with everyone, but
yes,
that's
typical. That's what I was bringing in. So,
yes.
And about how long, if you're going to do a full and you're able to do it in one day, how long does that take? Let's take the third-party pair out of it. How long would a comprehensive, targeted physical examination for your concussion patients take?
That will take me an hour.
Yeah. So what we're looking at here for our listeners is that most of the experts that I am bringing on here literally will take between minimum 1 hour, usually between 90 minutes and 3 hours of comprehensive subjective histories, physical examination, and then stress testing for whatever neurological system may be, or orthopedic may be, and cognitive as well. What's the word I'm looking for as I'm talking about cognitive delay? A deficit, cognitive deficit. I'm gonna leave that in there for the listeners so they can have a laugh, because I don't want to edit anything else out. But in all sincerity, like, we have to make sure that we're advocating also for third-party payers that are listening in, because these patients take time. You cannot rush a brain-injured patient through anything. A, they're going to be symptomatic, and B, you don't want to get false positives or negatives if they're just so symptomatic they can't tolerate a full one-session exam.
Right.
Wonderful work there. What are you seeing on average? How many weeks out? And I'm saying weeks because, again, we're not often getting folks days out with this injury as physios. How many weeks or what time on average are you seeing patients after their injury?
Yeah, so if I take out the professional athlete market, because I will see them day one, day two after injury, and they of course, because they're superhuman with everything, tend to get better really quickly. So we'll take them out of the population. And I would say on average, I'm seeing people 3 weeks after injury.
Yeah, that's pretty typical.
Yeah, and they'll take anywhere from, once I see them at that initial evaluation, anywhere from 3 weeks to 3 months on average. Of course, there's the people on average. Yeah. There's some that are a lot longer, of course. And then there's those fortunate few who get better really quickly once you give them a couple things to do.
Right. And then on those outliers, what are you seeing out? Are you seeing 6 months, 12 months, 5 years? What are you seeing in terms of your outliers?
So I would say we're talking more like a year plus. And then with the military personnel, retired military personnel, they've already had dysfunction and impairments for multiple years. And so now we're starting to teach a lot of adaptation type of exercises and trying to desensitize. So that's years in the making. I mean, that takes years. Yeah. It's already been years, so that takes years.
Indeed. So, Lenore, I was speaking with Dr. Furtado and Dr. Scott down south. Michael's in Texas, and Karen is at the VA in Tampa, VA. And what are you seeing from a dosage perspective, right? So, the heterogeneity of the injury is already through the roof. Every concussion looks different, although we have a lot of similar characteristics throughout. But we know, obviously, the pre-morbid history is so very important, what these patients are bringing to the table. But what are you finding the dosage from the vestibular standpoint? Are you underdosing because they're so symptomatic, they don't recover? Like, what are you finding from a vestibular rehab side?
Sure. So I would say I tend to err on the side of underdosing. Again, we're thinking of an injury that is a metabolic crisis, an energy mismatch. And so if we overdose, something else is going to fall apart because there's just not enough ATP and energy to feed all of those systems. So I would say I underdose, but I also, this is going to sound strange, but I treat dosing almost like I'm treating a tendinopathy. So I am okay with, while they're doing the exercise, to bring it right to the point of feeling any symptom, and then they stop. And so I don't push through symptoms, but I'm okay with working right up to the point of getting a symptom. And that has, I'd say anecdotally, over the years, adapting to that model has been the most successful for my patients.
Indeed. And just so our listeners are really, really taking all this in from Dr. Herget, you know, and again, we used to live, it's like Mrs. Doubtfire, it used to be one. We used to live in like the orthopedic musculoskeletal world. And the difference between a musculoskeletal injury and an orthopedic injury, per Dr. Stephen Flanagan at NYU, is the cognitive and behavioral components. And then I, as physio, add the environmental components as well. So Lenore is living in the tendinopathy world. I live in the knee fusion principle. So the knee fusion principle for me is, developed by Tara Jo Manal and Lynn Snyder Meckler at University of Delaware. Is, 2 days. Are we looking at 2 days? Is the swelling going down? No difference for me. Did their symptoms go up by 2 points? Very comparable to the knee fusion rule. And also, how were they transiently? So remember, guys, as we're dosing this rehab and giving this pace-graded exposure back into return to life, return to play, return to activity, return to parenting, whatever it is, just making sure that they're not now, we just did what seems to be a simple, benign exercise, and now the patient's in bed for 4 days because they're so symptomatic. And really connecting to Dr. Herget's, ATP neurometabolic injury here, we have to remember that the ocular motor system, the eyes, our eyeballs, take up about 2/3 of our brain's pathways. And our brain is like an only child, right? I'm an only child, so I try not to make these jokes, but I think I'm pretty well balanced here. But it is an only child, so it's glucose hungry, it's blood hungry. It takes up about 20% of our blood flow and about 500 calories if we're on a 1,500 calorie diet. So we're looking at about 1/3 of energy goes to the brain, and 2/3 of that is used by the visual system. So Lenore, what are you seeing with ocular motor and eye exercises and symptoms provocation with your patients there?
Yeah, I mean, if you dose too heavy, they feel lousy immediately. And before they even say anything, you start to see them physically pull back from whatever stimulus you're having them look at. There's a lot of eye rubbing, closing the eyes, head bowing position and postures. So you can read a lot as far as how they are tolerating this. And so once I see that, we stop. And if it can go away within a couple minutes, great. Maybe we'll do a little bit more. But I use a little bit of the Lynn Snyder Meckler 1 to 2 point scale as well. So if your symptoms go up by 1 or 2, I'm okay with that. Any more, we did too much and we need to readjust for next time, or readjust for your home exercise program. But certainly the ocular motor system fatigues quickly, because even when they're not doing their home exercise program or their rehab, they're using their eyes all day long unless they're sleeping. They don't get a rest. And that's something that's important for them to remember.
And you can't just turn your brain off, and you can't. That's legally called death, in this country at least. And also with our eyes, right? If your person has normal acuity 20/20 and they don't have any low vision issues, 70% of someone's sensory environment is coming through their eyeballs, through their vision. So again, it's very glucose, very energy heavy. And remember, this is a neurometabolic cascade of an energy imbalance. So really solid points there, Lenore.
Yeah, thank you.
From an interdisciplinary standpoint, as we wrap up in the next few minutes, from an interdisciplinary standpoint, just to finish up from another question that you hit it out of the park, who are your colleagues, your interdisciplinary colleagues that you're working with, referring to, and receiving referrals from?
Sure. I'll start from receiving from, so acutely from the collegiate and professional and some high school level athletes. It's the athletic trainer is number one. The team physician as well. And then as far as who I work most closely with, or referred, certainly it's either a physiatrist in our PM&R or a neurologist as our physician directed liaison. Then there's the neuropsychologist, sports psychologist, neurooptometry I often refer to, as well as our cardiac performance lab. So a cardiologist who does a lot with exercise intolerance and dysautonomia. If it's something that's presenting a lot more abnormal than what we can work on in the clinic, I get them involved as well. And certainly speech therapy, occupational therapy, nutritionist. Those are some of the ones we will reach out to as well.
Indeed. And, as we close up shop here, Lenore, what are your hopes, from a physical therapy standpoint? We have direct access as doctors of physical therapy in this country, the U.S., in all 50 states to a degree, at minimum on evaluation. And my issue with the concussion world from a healthcare standpoint is that the mismanagement of this injury is so much more prevalent than the well cared for concussion patient, because if we really have infinite ports of entry to access of care, and that initial point of contact really sets up that downstream trajectory or, upstream trajectory, but that downstream trajectory for potentially mismanaging the patient. Where would you like to hope to see, the physical therapist in this injury in the next 5 years?
I would love to see us as one, if not the first people that the patients see. I think when you spoke earlier about the fact that we can help assess and care for at least 5 of those trajectories, then we should be one of the people assessing them from the get-go, so we can help decide whom they should be referred to and seen by.
Just made my day there. Yep. I completely concur. From a very serious standpoint, we are accessible as physical therapists. We are affordable. And we essentially become care managers, not case, but care managers for this, because we're identifying the somatic issues and potential screening for cognitive, behavioral, and mood disorders as well. And we're referring and getting folks to the right place the first time.
Exactly.
And that is proven 1,000% in the musculoskeletal literature, and it's no different for this injury. Again, we're advocating for post-professional training. Dr. Herget was hungry for this, as has been everybody else on this podcast. And there's a lot of self-study here, collaborating with folks like Home Base, offering free 4-week courses on concussion and MTBI. There's other courses out there, including ours at Evidence in Motion, where I started our program. But I'll be honest, if you're going to commit to the EIM program, that's a significant commitment of 5 to 7 hours a week, sometimes 8 to 10 plus hours a week for a few weeks throughout the year, for a full year-long program. So I advise people, make sure you're committed to this, because it's work, and we all do this not to make the big bucks. We really are vested in this patient population. Right.
And it's I can't tell you how many clinicians or students that I've mentored who ask me, I really want to do this. I want to get into concussion management. What should I do? And that Evidence in Motion program is such a nice way to get the multidisciplinary education and care that you can come out a lot more knowledgeable and confident. And I would feel more confident advocating for those clinicians to see this population.
Yeah, and we do. We talk about degree bias heavily on this podcast and in the Evidence in Motion program. But again, I do not care what terminal degree that you own and have earned in your career, whether it be physician, DO, MD, DPT, Doctor of Physical Therapist, PhD of anything, OT speech. You have to have post-professional training, because no one has quality and by all means complete concussion education at an entry-level, discipline, no matter where you are, from physician to physio, and everything in between.
No, not at all.
So, all right. Well, on that note, I know that you're going to be on many times, whether you want to or not. I'm coming for you. So.
Happy to be. I love this stuff.
Yeah. So, and really, we're lucky to have you. The Boston area is lucky to have you as well. Lenore is my, number one person that I'm referring to in the Boston area, for a variety of reasons you guys are all aware of now. So, Lenore, where can we find you, whether it be social media or if folks need to reach out to do some case consultation or even some shadowing?
Sure. So I would say probably the best way to get me is good old-fashioned email, lherget@partners.org. It's LHER at partners. That's probably where I am the most, so I'll be the most responsive. I'm trying to get over my social media phobia and get into Twitter and all those things. I sound like my parents right now, but my Twitter handle is Lenore Herget. I believe that's what it's called, a Twitter handle, right?
Yes, that's what it is.
So it's just Lenore Herget, LenoreHerget. And I love educating, so I'm always happy to help, when I'm able to.
Indeed. And I just let our listeners know, I know you broke up a little bit on the email. It's lherget, LHERGET @partners.org. And by all means, guys, we are so happy to help, and we're so grateful for that you guys are tuning in and listening and deeply learning with this podcast. But please, we get so many emails, so we will get to you eventually. But if we're ever delayed by a few days or a week, just give us that time, and we're here to help, and we're happy to. Sometimes we just have to make sure we address all of our things first.
Well said.
Yeah, exactly. So just setting them up for success like you do your patients so well. Well, Lenore, thank you so much for coming on today to the Concussion Corner podcast. And I know we're going to do many more of these in the future. So I hope you have a great day.
Great. Thank you very much, Jessica.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.